next speaker is Dr. Dalal, who is well known across the country and the globe. He has a masterly approach of slowly unmasking the depth of the problem, and I'm sure we will enjoy the flashes of expertise during his discourse on heart failure. Dr. Dalal, please.
Thank you very much indeed. I'll quickly send my slides. I think we have been hearing about the importance of guideline medicated therapy. So what's important to remember is that why is it that we are not able to achieve this guideline mediated therapy? And we need to do something in order to improve it. And that's, I think, where the importance of the discharge checklist and the cardiac rehabilitation program comes. I think this point has been stressed many times before, but I think it's worth stressing again that patients are very vulnerable after the acute phase of acute decompensated heart failure. Approximately 25 patients will get rehabilitated in first 30 days, and mortality during the first 30 days may reach as high as 10%. And you can see, especially in Indian patients, because of the high incidence of diabetes and ischemic heart disease, the lack of proper guideline-mediated therapy, even in major hospitals, as Dr. Ponde showed, is a cause for concern for all of us. Now, there's a therapeutic inertia, which is the reason why the patients are not on full guideline-mediated therapy. And they fail to receive evidence-based therapy, or sometimes they do not receive any therapy at any optimal dosages. When you talk of the factors relating to this not reaching the guideline therapy, there are factors related to the clinician. There may be lack of awareness, for which this particular session would be very useful in terms of the heart failure management. People have limited time and therefore do not spend time, or limited experience. Patient is doing fine. We heard that again and again. Patient is doing fine is not a reason for not giving full dose treatment. And then therapeutic inertia can be from the patient's point of view, reluctance to change the medicine, poor adherence, comorbidities, patient not informed of the importance of taking the medication. How many patients actually know that changing from an AC inhibitor to an ARNI would significantly reduce their mortality? I think that needs to be drilled into the patient. And of course, there are systemic problems like insurance, understaffed clinics, remote locations, unavailability of drugs and specialists. So multiple factors lead to that. And that is why we need a checklist in healthcare, because healthcare today has become a complex subject and a substantial number of patients at discharge do not get the therapy. So I think checklists are a way to prevent mistakes and to better prepare in cases of unexpected catastrophe and to implement a common guideline for these patients. If we look at the Indian scenario, and that again has been pointed out again and again, suboptimal treatment actually leads to rehospitalization. You can see, as Dr. Ponde mentioned, only 25% are receiving therapies. And you can see, yes, diuretics, majority of patients are on. And we know that diuretics actually do not reduce the mortality. But if you look at the other drugs, they're almost all less than 50%. ARNI being just ARNI, aldosterone antagonist, and other optimal treatments just achieving a goal of around 20%. So I think checklist therefore improves the guideline-mediated therapy, and therefore I think that all hospitals need to have a checklist. Now, again, I feel the checklist does not need to be very extensive. Again, if you look at heart failure discharge checklist, does it actually help? That's the other question that we need to ask. Does a checklist actually help? Yes, it actually does help. 2 times more patients will receive a guideline medical therapy, and 5 times more patients will get up-titrated. So significant number of patients will actually be given the treatment that they deserve, and more of them, about 5 times more, will be up-titrated. So that is the importance I think shown with the checklist. If you look at more specific things between the pre-implementation group and the post-implementation group, you can see a significant improvement in the use of beta blockers, MRAs, AC inhibitors, and even things like vaccination, which is so very important in patients with heart failure and which gets forgotten, significantly increases. Discharge checklist also reduces readmissions. 10 times reduction in readmission at 30 days and 2 times reduction of admission rate at 6 months. So clearly, checklist is not just a theoretical thing. I've shown out here that it improves therapy, improves titration of dosages, and reduces hospital admission, and of course, therefore, mortality. Now, different discharge interventions needed in Indian patients. We know that Indian patients are a younger age and therefore more difficult to make them take treatment for a long period of time. Also, do not forget that rheumatic heart disease may be a different etiology for heart failure and requires a different form of therapy. Males are much more commonly affected in India than females, and prevalence is much higher of diabetes which contributes to the heart failure. So we need to simplify the transition of care by ensuring, so we need associations and societies to recommend the checklist, which is what all over India we are doing. Hospital administration should roll out policies, and it's important to get the hospital administration on board. If you want to start a heart failure clinic, the hospital administration must be a part of it. Yes, there may be an initial increase in cost, but overall, it is both to the benefit, both to the patient and to the hospital financially as well. Attaching a checklist at the time of discharge and making a checklist before the patient is discharged is extremely crucial. And of course, encouraging the practice of filling up this checklist during follow-up. So no point just attaching one checklist and then nobody looking after it at the end. It must be followed up and looked at and corrected and implemented at every point in time. It's best to have a simple checklist. As you know, the more pages in the checklist, less it's going to be managed. So a checklist must look at heart failure management, treatment optimization, and non-pharmacological measures as well besides the treatment. The checklist should be relatively small, shorter time duration to complete that checklist, because you know everybody's in a rush. A checklist which takes 15 minutes to fill is probably not going to be filled. Appropriate use of font and boldface colors to enhance the important points. And again, very important, regular updating and validating the checklist based on experience and guidelines. So checklist is not forever. Every year when guidelines change, the checklist may need to also be changed. A checklist can focus on different aspects of the problem. One is a checklist which looks at focusing on the diagnosis and investigation. This is a different type of checklist. It's a checklist which talks about transition from ICU to the ward at the time of discharge and at various follow-up visits. It looks more at etiology, comorbidities, reason for decompensation, monitors the patient's weight. It also looks at the parameters of the patient, resting heart rate, respiratory rate, blood pressure, signs of fluid overload, and various laboratory measurements, and what are the non-pharmacological measurements. So this is like a more complete data of a patient. And I think the importance of this data is that when patients shift from one hospital to another or another city or another country, this checklist of 2 pages will give the next doctor a complete idea of the patient's problems, the etiology, basic parameters, and drug treatments, and therefore will allow a better continuation of heart failure treatment. So it should not be that the patient goes to a high-ended heart failure clinic, gets optimal treatment, then shifts to another city, and then everything is forgotten and their drugs drop off, etc. So I think this checklist is a good idea of continuation of the patient's care from one place to another. And then you have the other checklist, which of course was published with Dr. Kerker as the chief author. And this checklist, I think, is very important and focuses on optimization of guideline-mediated therapy. So here we are talking more of importance of therapy in this checklist. And I think this is an extremely important checklist. So you have restricts, you can have a checklist starting from transmission to ICU to the ward. But I think probably if you were to do a single checklist, I would say at the time of discharge, because that's extremely important. And then, of course, follow-up of this checklist is also extremely important. So you choose a drug, for example, ARNI, you write down what medicine you use. Dosage is very important because we mentioned very often that optimal doses are not used. And we very well know that patients are hypotensive, various problems are there, even at the time of discharge, and the dosages may be small. We know that we want to start all 4 drugs at the time of discharge, and obviously it is not possible in most patients to optimize full dose of all 4 drugs. So therefore, dosage needs to be mentioned, because when the patient comes for follow-up, you need to see whether that dose is appropriate or not. It may require an increase of dose, or it may require a decrease of dose. Even if the patient is stable, blood pressure is okay, blood pulse is okay, the dose needs to be increased. On the other hand, if creatinine has shot up, potassium has shot up, the dose may need to be reduced. And this should be followed up at every follow-up period. So you look at important drugs like ARNI. If ARNI is not used, then an AC inhibitor, beta blockers, MRAs. So all the major drugs we talk about, again, diuretics. I think it's important to look at the dose of diuretics very carefully. And the importance of looking at the dose is that what we want to do is you want to reduce the diuretics as much as possible during follow-up. If preferable, the patient can be off all diuretics and can just be on an SGLT2 inhibitor along with the other drugs. So I think one of the reasons why we are not able to optimize the dosages of drugs is because we use too much diuretics and the patient is hypovolemic. And this leads to fall in blood pressure, a rise of creatinine, and that makes us reduce the dose of ARNI and SGLT2 rather than actually reducing the dose of diuretics and continuing the dose of ARNI, etc. Again, at the time of discharge, it's very important to write why a drug was not prescribed. For example, at time of discharge, the patient's creatinine was high. So at that time, we started an ARNI, but we did not start SGLT2 or vice versa. That must be mentioned out here. So when the patient comes for a follow-up, you look at why the patient wasn't treated. Okay, that potassium was 6 at that time. That is why ARNI was withdrawn or not started. Now, after treatment, potassium has come down to 4. It's now a good time to start ARNI. So why the drug was not prescribed, the reason for that is extremely important. It also holds the clinician responsible as to why he did not prescribe the drug. It cannot be that simply there was inertia. 20% of patients are given, as the 80% are not given. What is the reason for that? So if your doctor writes the reason, I think the next doctor or at next follow-up, that reason can be checked and corrected. The reason may remain and you may still not prescribe the drug, or the reason may have now gone and therefore you need to prescribe the drug. So I think the name of the medicine, the dosage, and the reason for not prescribing are all extremely important. There are other things besides the pillars that can be missed out. For example, IV iron. We know that treatment with IV iron is very important for patients with iron deficiency and heart failure. And this needs to be charted at every time. Patient may be iron deficient, iron may have been given, but again becomes iron deficiency. And then we need to look at that. Again, something which we forget in most of our heart failure patients, the vaccination. And certainly in my hospital, at least in my care, vaccination has considerably increased after I put the checklist. Because many patients do not get vaccinated when they get discharged from the hospital because they're sick, they've just recovered. But during first follow-up, as I go through the checklist, I remember vaccination and I send them immediately for both influenza and pneumococcal vaccination. So we know that influenza and pneumococcal both can lead to increased heart failure and death of a patient with a poor heart function. So vaccinations are important. And again, thinking about medical devices, at every point in time, we need to think, does the patient need a CRT? Does the patient need ICD? Is the patient very sick and now we should think of heart transplant? So I think this medical device thinking is very important. So these things can be easily mistaken and forgotten in your rush in the OPD. But if you have a checklist and you go systematically through the checklist, you'll certainly pick up these points. And then, of course, advantage of checklist, as I mentioned, it should be used by all people, public and private sectors. The hospital administration must take an important part in rolling out this because without hospital administration's help, most of these things cannot be done. So I think we mentioned also the significance of documentation. Many times patient doesn't know what medicine is patient. Patient forgets to bring the discharge summary or the last OPD paper. So the proper documentation and this checklist, one copy should be with the patient, one copy should be with the heart failure clinic or with the doctor. And we know that when we talk of cardiac rehabilitation, we need to go beyond the checklist. We look at risk modification and risk factors of all. So not only control heart failure, control blood pressure, control diabetes, overweight, diet, so many psychological risk factors. Please do not forget, heart failure patients require psychological support. They require education. That's when they will take the drugs and that's when the compliance will increase. Please remember exercise. Most patients with heart failure are told by their spouse to lie down, do not walk, do not do this. But we all know that exercise and a supervised structural program can actually significantly reduce both hospitalization and mortality and morbidity. And finally, multidisciplinary strategies and reducing heart failure hospitalization can benefit in terms of a 25% reduction in mortality, a 24% reduction in heart failure hospitalization risk, and a 19% reduction in all-cause hospitalization risk. So cardiac rehabilitation programs, the formation of a heart failure checklist, these are not just theoretical things. They're, in my opinion, as important as the 4 pillars. So I think the whole spectrum of cardiac rehabilitation and a checklist should be, according to me, the 5th pillar, which must be implemented along with the other 4 pillars. Thank you very much indeed.
Thank you, Dr. Dalal, for an excellent talk. I think the lack of awareness of the current therapeutics in heart failure among the physicians and the practitioners is one of the reasons of suboptimal GDMT, and all attempts must be made to disseminate the current understanding and treatment of heart failure.
I'd just like to say one point. I think Dr. Dalal has given a very, very lucid presentation. And I feel there's a lot of legal implementation of this as well as ethical implementation. And education is our his last message is very important. We talk of quadruple therapy, but quadruple therapy is totally incomplete without the 5th pillar, which is, I think, a very important message. That is the only way. And checklist is very important. And I think there is a need now in every hospital. We must have a heart failure clinic to enhance the potential and usefulness, implementation, and success of GDMT by checklist.